Thanks everyone for joining us today. My name's Kate Leifheit. I co-lead the Social Epidemiology Student Organization with Daniel Antiporta. So welcome everyone today. We're so happy to have you here. This is a great turnout, and we're really so lucky to have Dr. Mary Bassett here to give our annual Social Epi Lecture. And since we have a captive audience, we wanted to give you all a flavor for what Social Epidemiology Students Organization does here at the school, particularly because this is our 10th Social Epidemiology Lecture. So SESO aims to bring together students and faculty from across the school to discuss theory and methods related to social epidemiology and the social determinants of health. And the two main things we do are we lead a monthly journal club, and then we have an annual lecture. So you know what the annual lecture is because you're all here. This is the journal club. We have students and faculty from around the school. We read sort of usually a very recent cutting edge paper in the field, and we pick apart the methods and we talk about social justice. So please join us. At the end I'll have my email if you want to get on our listserv. So particularly because Dr. Bassett's talk is themed around history, I wanted to give you a flavor for the history of social epi here at Hopkins. So our organization was founded in 2006 by 3 renegade PhD students. This is not a very flattering picture of them, but they were profiled in the Hopkins magazine. This is Brian James, Ari Nandi, and Manuel Franco, all of whom are very accomplished epidemiologists now, despite what you might think from that picture. And the main reason that they founded the club was because they wanted to bring in experts in the field and have an opportunity to meet them, to talk to them, and also to sort of raise the profile of social epi in the school. So they started big with Sandro Galea. At that time, he wasn't a dean, but was still a big name. Followed him up with Ana Diaz-Rue. Then on to Michael Oakes, so we're batting 100. Nick Christakis and Leonard Syme, thank you. And then it could have ended there. You'll see that there's a gap here between 2010 and 2015 where we didn't have any lectures. But then a couple of heroes came along who are in the audience here today. So Usama and Emily sort of reinvigorated the Social Epidemiology Students Organization and got our lectureship back on track. So in 2015, we had Maria Glymore, Jay Kaufman in 2016, Ari Nandi, one of our founders, came back in 2017. Last year, we had Mahasan Mujahid. And today, we're so happy to welcome Mary Bassett. So that's kind of our history. And we want to thank some of our sponsors. So the Student Assembly generously has funded this lectureship for many years running. This year, we're also really lucky to have co-sponsorship from the American Health Initiative and the Office of Public Health Practice and Training, so thank you for that. Thanks to the Department of Epidemiology, so Laura and John helped us advertise this and are helping out with logistics today. Thank you to the chair for also advertising and supporting social epi in the department more broadly. And then thanks to our advisor, Lori Dean, who's just fantastic, and to my co-leader, Danielle, who is also fantastic. Thanks to past SESO leaders who got us here today, Emily and Usama in particular. So we're having a reception after the talk in the Anna Bacher room. Please join us. There will be good food from Water for Chocolate, and you'll have an opportunity to chat with Dr. Bassett. If you're tweeting, so Hopkins Epi 100 is our centennial hashtag, and then JH Social Epi 10 is the hashtag for this event. So let's get that trending. And then my email's at the bottom. So if you want to come to our journal clubs or hear more about what we do, shoot me an email. And without further ado, I'm going to bring Lori on stage to introduce Dr. Bassett.
Thanks, Kate, and thanks to Kate and Danielle for organizing this event and successfully coaxing Dr. Bassett to come, which Dr. Sharfstein told us she'd been asked twice before. And it wasn't until Kate and Danielle asked that she actually agreed to come, so thank you. I'm pleased to introduce our 10th annual speaker, Dr. Mary Bassett. She was recently appointed director of the FXB Center for Health and Human Rights and is professor of the practice of health and human rights at Harvard T.H. Chan School of Public Health. She's led an illustrious public health career and has even had a career in history documented in The Lancet, #life goals, at least for me. She's had many awards and honors. She's an elected member of the National Academy of Medicine. She's received the Kenneth A. Ford Lifetime Achievement Award from Columbia, as well as a number of other awards for women's health and being a champion of women's public health. She spent 30 years and has had a diverse public health experience which has spanned academia, government, and nonprofit work. She's been always devoted to promoting health equity and social justice, both in the US and abroad. I think her career is a great example of the way in which a public health career can be structured to have impact, and to have that impact working across many different sectors. So as an academic, she's been a member of the medical faculty at the University of Zimbabwe for 17 years, during which time she developed a range of AIDS prevention interventions. She served as associate professor, clinical public health and medicine at Columbia, and in her government roles, she was appointed by Tom Frieden as Deputy Commissioner of Health Promotion and Disease Prevention at the New York City Department of Health and Mental Hygiene. That was from 2002 to 2009, and of her accomplishments there are things that she's trailblazed that many of us admire, things like the smoking and trans fat bans in restaurants, posting calories on the restaurants, increases in cigarette prices. Then she went on to serve as commissioner of the New York City Department of Health and Mental Hygiene, where she was since 2014, where she worked to address issues of structural racism as a social determinant of health. In her nonprofit work, she went on to oversee the Africa AIDS portfolio as Associate Director of Health Equity at the Rockefeller Foundation, Southern Africa office, overseeing its Africa AIDS portfolio. Her social justice work is really shaped by her upbringing. She was raised in New York City in a family of civil rights activists, received her undergrad in history and science from Harvard University, and that's also where she first linked her commitments to health and social justice through her volunteer work through Boston's Black Panther Party's Franklin Lynch's People Free Health Center in Roxbury, Massachusetts. She also received an MD from Columbia University's College of Physicians and Surgeons and her MPH from the University of Washington. So we're very delighted to have Dr. Bassett. Dr. Bassett, it's your ball.
Thank you. Oh, it's a real pleasure to be here, and I need to begin by giving some thanks. I want to thank David Celentano for providing a place for social epidemiologists in the Department of Epidemiology. That doesn't always happen. I imagine there's social epidemiologists scattered all over the school, but it's wonderful that there's been a niche for them there. If the students don't know that, they should know it. But of course, I most of all want to thank the students who invited me here. It's true. I've been saying yes first to invitations from students, and Katie Leifheit and Danielle Antiporta Penalosa have been wonderful in organizing, and they're very lucky to have as their faculty advisor Lorraine Dean. When Katie emailed me, she asked me to give a talk, and I said, well, I'd speak about the public engagement with the problem of racism and the limits of data. When she contacted me, I was in transition. You know, I'd been health commissioner for a little over 4 years and was taking up the position at Harvard. And I was reflecting on all the unexpected things. 3 years of declining life expectancy in the United States. I don't think any of us ever really expected that. The surge, relatedly, the surge in opioid mortality. And of course, our unexpected occupant of the White House. All of these had me reading history. And I was interested when the students at Harvard, who organized a one-day symposium, a conference called Decolonizing Global Health, that the first panel was entirely composed of historians. And you all should know about this Dutch historian who lit up Davis by repeating that all they needed to talk about at this elite conference was taxes, taxes, taxes. So history is on my mind these days, and of course it's also Black History Month. I'm sure that around the school there's been some recognition of that. But that's why we're going to start today with talking about W.E.B. Du Bois, one of the towering figures of intellectuals and activists of the 20th century of any race. Then I'm going to talk a little bit about racism, and then I want to show you a handful, just sort of a teaser, of what I think this type of framing did to help us improve the quality of our data analysis at the New York City Health Department. And then I'm going to wind up by telling us all that we need to speak up and speak out these days. Now's the time. So let's start then with W.E.B. Du Bois. And I'm advancing them on the slide here, but not on the computer. So I don't know why that is, but I'll just keep looking here, everyone. Now, maybe I can just ask for a show of hands. How many of you have heard of W.E.B. Du Bois? Oh, wonderful. Because he was somebody who we all should know about. And as you can see, he lived a very long life. He was born right after the end of the Civil War, and his passing was actually announced at the March on Washington, which spanned from the end of the Civil War through Reconstruction up to the Civil Rights Movement. And he was impeccably educated. First African Americans to receive a PhD from Harvard University. He then went into the now really growing field of sociology and went to Europe, to Germany, to study sociology. And he produced a whole range of very varied masterworks. Probably the most famous of them was Black Reconstruction in America, but I'm going to say a little bit about the Philadelphia Negro, which was really, we should consider a piece of public health research. Although I have to tell you that it wasn't on the shelves at the Countway Library at Harvard. But this was a book that he wrote after he'd finished his PhD, when he'd embraced this idea that was true of the whole burgeoning field of sociology, that we could study society with the same kind of scientific methods that we studied the human body, that it was equally a scientific endeavor. And he focused his work on a single ward in Philadelphia where he went and moved with his wife, personally with one assistant, conducted over 5,000 surveys of this one ward. And his goal was to completely characterize the position of this Black population in Philadelphia. And he began, though, with an analytic frame that would characterize his work, that we have to ask first, what is the condition of these group of human beings? Who is it composed of? What subgroups and classes? What individuals are being considered? And particularly the last sentence I'd ask you to take note of, that he said we have to focus particularly on the environment, and including the physical environment and the far mightier social environment. I'm sure you'll agree that this was published in 1899. A little hard to believe. It sounds very modern. And he went on to produce tables after tables of data. Here were the first data showing that between 1820 and 1896, there'd been a 70% mortality decline among people of African descent in this one area. That the mortality varied substantially among Blacks by particular neighborhood, ranging from a low to a high that was threefold different. And he also compared Blacks to whites and showed what we still see today, big excess in early life and in later life, with Blacks showing some survival advantage. And he then continued to focus on context by talking about the sanitary surroundings that accounted for the enormously high death rate in the Fifth Ward. That was the one with the very highest death rate. I think I listed it as a percent. It should have been 48.5 per thousand deaths. And he noted that that was the place which had the very worst conditions. And he noted that the leading causes of death were tuberculosis, and he made this observation, which was really in direct challenge to the race scientists of the time, when he pointed out that people used to say that the Irish were genetically vulnerable to TB. They said that the Irish actually were also genetically vulnerable to rheumatic heart disease. It was their red hair and pale skin that made them more likely to get rheumatic heart disease rather than their poverty and undernutrition. And then he continued this real focus on data. And these are some slides that I just located. It was from a book that was published in 2017. The Paris Exposition was allowed a special booth that was devoted to the American Negro. And DuBois and his students, he was then the first professor of sociology at Fisk, went there with these beautiful graphics. Hand-drawn. This was land ownership. This was the black population in the United States. This was really interesting. He compared the age structure of the Negro to the age structure of the French. I can't tell you how outrageous that would have seemed to most white Americans, to even begin to compare African Americans to a European population. And then he had these graphics. This is showing the expansion of taxable property that are, wow. And the people who put these together said that he was a leader in infographics. But I think that he was connecting and showing that this group of American Negroes at a poorly resourced Southern university knew about all this as well. And then came Souls of Black Folks. So something completely changed about W.B. Du Bois. This was a completely different type of book. It's a small collection of essays. It was published in 1903, so not that long after he was putting together the report on the Philadelphia Negro with all the charts and graphs, going to Paris. This was completely different tone. It's claimed by people who view it as a work of literature. It's claimed by people who view it as a work of philosophy. In this, he began each chapter with a bar of music from Negro spirituals, no words. Each chapter begins with a bar of music. These so-called primitive music he was elevating to the sort of beginning of each chapter of his book. He famously said in this volume that the problem of the 20th century is the problem of the color line. It's how he began and ended the book. And he also talked about this idea of the black population living within a veil, of the concept of double consciousness, of always seeing yourself through the eyes of others, as well as seeing yourself as your own person. And this kind of enduring separateness that people of African descent experienced in their everyday lives throughout their lives. And this was also where he challenged Booker T. Washington, the leading black leader of the time, on his idea that blacks should be limited to industrial education. So this book signaled a departure by Du Bois from his complete confidence that data that showed, despite everything, life expectancy was increasing, mortality rates were falling, home ownership was increasing, the acquisition of wealth by the black population was rising, both in Philadelphia and Georgia. He decided that he was no longer going to focus only on the data and began to commit himself to a life of activism that characterized the remaining of his working and very long working life, in which he moved from being a scholar to being an activist. Now, why did this happen? Why did somebody with arguably the most elite training that a person could have at that time, an absolutely unusual level of accomplishment for anyone, particularly a person of African descent? Well, it had to do with what had gone on in the United States. You know that years after he was born in 1868, 1865 was the Southern surrender. And then things changed. In a period of time right after the Civil War, when millions of now free free slaves were seeking a place, they had no place, no jobs, many Southern states introduced what were called the Black Codes, and basically were seeking to reintroduce the enslavement of Africans in the South. They use many of the signifiers of slavery. They use whipping as punishment. They sold people as contract laborers on the auction block. That came to an end with the end of Andrew Johnson's presidency, who took over after Lincoln, and the beginning of Reconstruction. And a series of very hopeful amendments were made to the U.S. Constitution. The important one, the 14th Amendment, well, of course, the 13th was the one that ended slavery, then came 14th, bestowed citizenship, and the 15th, the right to vote. The citizenship one was very important, obviously. But then in 1877, Reconstruction ended. So by the time that DuBois was beginning his work as a bona fide sociologist, the decision on Plessy versus Ferguson had been made, and separate but equal was now the law of the land. It wouldn't be overturned until 1954 with Brown versus the Board of Education. So arguably, it was the context in which he worked and the growing criminalization of people of African descent, something that had characterized the United States since its founding, that led Du Bois to determine that equality would never be achieved with data alone, that advocacy would always be necessary. This year represents 400 years since the first person of African descent came to these shores. And it has been a story of rising rights and rolling back rights. That happened with the end of Reconstruction and the introduction of the Jim Crow period, and then a rising of rights between 1965 and 1980. And now we have another period in which we've seen a huge rollback of rights for the the population of African descent. Now, additionally, there were other people using data. And this was part of what gave Du Bois the idea that data are always subject to interpretation. This is a man named Frederick Hoffman. He worked for an insurance company, Prudential. It was around back then, who knew? And he analyzed the 1890 census. And he noted in it the high mortality rates of the population of African descent. But he interpreted this in a different way. He argued that this population was showing its unfitness. The reason that there were such high mortality rates was because the population wasn't doing well since it had been released from slavery or freed. And he argued that it was because people of African descent were unusually disease-prone. And he, in fact, made the statement that there was not going to be much problem with people of African descent in the United States because the population would vanish. It was simply going to die out. And he wasn't the only one. He had a different attitude towards immigrants, by the way, who also had high mortality rates. He felt that the treatment of the mortality rates among immigrants represented the lack of democracy in the United States and the failure to assimilate immigrants. But his interpretation of people of African descent was entirely different. And Jane Addams, who we all revere as the founder of social work and the founder of the settlement house movement in the United States, also had deeply held racial beliefs. She focused almost all of her settlement work on European immigrant populations. And the reason for that was because this population was seen as having the legacy of civilization behind it, whereas people descended from African slaves had only a legacy of barbarism to draw on. Now, so that's the sort of context in which we are today a context that is not that much different from the sort of context that changed DuBois' attitude towards his work as a collector of data and a designer of surveys. This is a graphic that was designed by actually a Baltimore artist. And what it was designed to show is in the arc of history, most of it, as you can see, is in the red, the period of African enslavement. And the point, they do it since 1954. Other people would place that since the mid-1960s when the Voting Rights Act and Civil Rights Acts were passed. That is relatively small. So I had, it's all more complicated than red, yellow, and green. I'm a product of that period between 1965 and 1980. That was an opening up in U.S. history, which Johnson, if it hadn't been for his stance on the Vietnam War, would be more revered for than he is. That green bars there show how I've chopped it up. That even the period of green has had periods of advancement and retrenchment. So now we're going to talk a little bit about racism. And that, I would argue, is what underlies that arc and all of the back and forth that we experience in the United States as a result of the really foundational commitment to the notions of white superiority. The taxonomy of racism that I use, that I find useful, divides it into internalized, interpersonal, institutional, and now we're going to spend a little more time, although I'm running short of time. Am I still okay on time? In terms to talk about structural racism, a phrase that's being used more and more widely, but reflects a whole range of ideas. Now, internalized racism is probably best exemplified by a study that was actually included in the Brown versus Board of Education suit before the Supreme Court. This is a picture taken from the famous doll experiment, in which black children were asked to pick between a black doll and a white doll and identify which doll they liked, which doll they thought was nice, which doll they thought was intelligent, I still tear up when I think of this. And a high school student in New York actually repeated this experiment not that long ago. And the black children almost always picked the white doll as the nice doll, the intelligent doll, the good doll. And it showed the ways in which living in a racially hierarchical society had influenced these children's view of themselves. So that, the one that we almost always talk about is interpersonal racism. It's in this category that we would put the idea of implicit bias, which is getting more and more attention these days. It's the kind of racial prejudice that's acted out between individuals based on beliefs that they may not even be aware that they have. And it reflects all of those, microaggressions and unintentional slights that can occur between individuals, as well as, when we talk about implicit racism, we shouldn't forget that explicit racism still is very much present in our society. And then there's institutional racism, which reflects the actions of a single institution. That's a photograph from New Orleans, where that little girl, clearly in her Sunday best, was being led by court marshals to desegregate a school in New Orleans, and there were riots for 3 days after her entrance into that school. So this is the types of discriminatory practices that exist within single institutions and characterize many institutions in the United States. Experiments continue to be done when, Brad Jones applies for a job as compared to Jamil Jones, that show that on the basis of name alone, people can be excluded from consideration for jobs. In fact, one study showed that if you are identifiable as white and tick that you have a felony conviction, you still have a better chance of having an interview than a person with a name that identifies them as African American. Then the last is this idea of structural racism. And I'm just going to take a moment and read all those words because it's too many for you to read by just looking. And this reflects the interconnected institutions whose linkages are historically rooted and culturally reinforced, and refer to the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems that in turn reinforce discriminatory beliefs, values, and distribution of resources, which together affect the risk of adverse health outcomes. So the big distinction here is it's not one institution at a time. It occurs across institutions, and it may also just be embedded in the culture in the way that we describe ourselves. And there are all kinds of ways in which racism is linked to health. Some of them are listed here. Some of them result in people making what all of us here would agree are bad decisions about how to behave. Maladaptive behaviors is on the list there. But this framing asks the question, why would people make these decisions? In what context are they making these decisions? And doesn't view those as simply the result of individual inadequacy. So I think of structural racism as really the platform on which all the other forms of racism survive and thrive, that it reflects the basis for internalized racism, interpersonal racism, and institutional racism, that it's antecedent to all of the social determinants of health. We can today have conversations about the social determinants of health and never mention the word racism. But we should always consider that the social determinants are filtered through the lens of white supremacy and black inferiority that has so dominated the ideology of the United States. And then we see the effects of racism mapped on our cities. I think that I did this because I'm now in Boston. And this came from BU, actually. I don't know Boston that well, but I guessed right away that this was a black neighborhood. Yeah. It has the highest premature death rate is in Dudley Square. And these maps are used to demonstrate that, here to here, that's more than twofold difference in premature mortality, just miles apart. And this is a way of saying to people what's going on here, that we see these differences. This is New York City. You can have an 11-year gap just within miles. And I don't think the 11 years is visible here because the neighborhood with the 11-year gap isn't on the public transport system. So, which is another part of how things work. And of course, in New York City, we often put together these maps. This is premature mortality. These are a number of different causes of death. This is childhood hospitalizations. This is HIV. This is diabetes, and this is hospitalizations for drug poisonings. All very different. You all know this, and you're familiar with these maps. All type of maps, all very different pathogenic pathways. But they have very different etiologies, but the same neighborhoods, you will agree, light up. Neighborhoods that you don't have to be from Boston to have heard of. East and Central Harlem, the South Bronx, Central Brooklyn, are all neighborhoods that are, people at the health department told me I should stop calling them the sickest neighborhoods, because they do have the highest disease burden, but these are the neighborhoods that invented hip hop and, you know, have all kinds of cultural assets that we all have benefited from, but do have the highest disease burden. And of course, health isn't the only social outcome that tracks with these neighborhoods. Just about any adverse social outcome, high school completion, incarceration, poverty and unemployment, all track with the same communities of color. This is part of the fact that in New York City and in many places, to be black or Latino is to be poor, and to be poor is to be black or Latino. And we could also give a heading to these slides as the health effects of racism. New York City is very segregated. It's one of the most segregated cities in the United States. 80% of whites or blacks would have to move. That's the dissimilarity index. And this is what I wanted to point out to you. These are redlining maps. And these are the same neighborhoods. That 80 years later, all of you heard of redlining. This was the decision of federal government not to make home mortgage loans in these neighborhoods. Owning a home is a principal source of acquisition of wealth and a principal mechanism for intergenerational transition of wealth. And these neighborhoods that I highlighted, I've shown those maps a million times, and I never thought about redlining. Why do these neighborhoods look like that? And part of what ensured that they did was the government-supported policy of redlining. So I like the question that we should ask ourselves, a simple question about what explains racial differences in health. And if somebody says that the problem is the people, we should interrogate it as a racist idea. And very quickly, because I'm running out of time, I wanted to show you a couple of examples of how the health department applied this kind of lens to looking at data. This is a graph that appeared above the fold, which means you see it on the very front of the New York Times. I learned as health commissioner getting above the fold is a big deal. This is done by Princeton researchers. It showed this very alarming observation of rising mortality in this narrow age range of white men. Now, it turns out, though, if we look at what's happened to life expectancy in the United States, these are other wealthy countries. The United States began pulling away from its peers about 1980. So this problem with our life expectancy is not brand new. So that's important, looking at history. And another part of looking at that famous graph, which generated a lot of media attention, is to think about the graph that they left out. This is black mortality rates. This is when you put it on a different scale. It doesn't look, it's interesting that they compared themselves to Europe. The whites, this is only whites compared to Europe, and Canada, and Australia, wealthy countries. But here is the line for blacks, also has leveled out, remains 50% higher. And Case and Deaton, very accomplished researchers, when asked why they didn't put this line in the graph, said that it wasn't what they were interested in looking at. But the problem with the graph that they were interested in looking at is it implied that everybody was on track. except for this group of whites. That this is on track, even if it's 50% higher. And even if, I don't know how many years it's going to take, to accomplish equity unless we do something about it. And then one last example. How am I doing? 5 minutes? Still 5 minutes. I thought you said 5 minutes before. Oh. Wow, well, you all can ask me questions and I'll go back. I want to make sure we have time for questions. I'll slow down a little bit and tell you about an effort that was done with emergency preparedness in New York. This is something that makes sense in New York City because New York did have the World Trade Center attacks and had the anthrax attacks. And so the health department was charged with coming up with a strategy for distribution of biologics in the event of some kind of attack. And the way to do it was by creating what are called points of distributions. These were all mostly elementary schools. There are 160 of them identified around the city. And the planning began in earnest. There was in 2014 a no announcement, no warning drill, which showed that the city could get 30 of these pods, as they're called, up and running within 8 hours. So we were feeling really good about this, the planning and the work that had been put in place. And then we, though, applied a neighborhood lens, which in New York City, as I've said, is also a racial lens. And we used the assumptions of what had happened in New York City after 9/11, when everything was shut down. The bridges were shut down, the tunnels, the highways, the transit system. So we said, let's think if a pod had to be launched, and these were led by people who had training and continuous training throughout over time, and then staffed by people who would get just-in-time training. So you had to have the pod leadership there. And let's imagine that the pod leaders had to walk to the place where they were going to distribute. And what we found was, using these assumptions, the South Bronx, the poorest county in New York State, would have severely undercovered areas that they wouldn't be able to provide leadership to these pods. So by applying a neighborhood lens, something that really was the team took on with adopting a health equity approach, they saw that we would not be in the position of equitably covering the city. And once again, the areas that weren't covered were the areas that had been redlined in the 1930s. Baltimore has had redlining. I don't know what neighborhoods these are, but you probably do. And we're probably right there. Because academic medical centers usually are located in poor neighborhoods. And so years after the end of redlining, we still have these very marked effects. These were policies made by people, supported by government, enforced by banks, real estate agents, private ownership organizations. It's an example of structural racism. Multiple institutions working together. And that's why I hope I've given you a taste of why the numbers alone will never be enough. We have to understand why we have the numbers we do. We have to understand our history, because data matter, but they'll never be enough to overcome racist ideas. We're not going to settle those ideas with numbers alone. I want to, before I end, acknowledge Bill Jenkins, who some of you in the audience may remember as a pioneering social epidemiologist who passed away last week. And for me, as a young In those days, I did call myself an epidemiologist. Living in Zimbabwe, I was a member of SAFI, the Society for African American, I can't remember what the PHI stood for, but he was a pioneering figure. We lost him before his time. He was just 73 years old. And with that, I thank you for your attention. I'd just like to ask the organizers, do we have time for any questions? Okay, great.
Raise your hand and we'll pass.
Questions?
Thank you for your talk, Dr. Bassett, and for coming down to Baltimore. Toward the end, you mentioned that academic medical centers are located in poor neighborhoods, and I wondered why that was, if you could briefly explain. Thank you.
Oh, well, it's called clinical material. Patients. Historically, many academic and public hospitals have been located in poor neighborhoods because they are teaching institutions and they need a population of patients to teach on.
Isn't that true at Hopkins, that at Harvard Medical School, that the people in the neighborhood just adjacent to the Harvard Medical School is actually being filled in the Harvard hospitals?
Oh, you mean that they were excluded from the Harvard hospitals?
Yeah, and they went to
Boston City Hospital. Yeah, that's possibly. That might well be true. There's just been recently an analysis done of the New York City hospitals, and their academic medical centers are often paired with a city hospital, and they preferentially ship their poorer patients, their uninsured patients, well, that appears to be what they do, to the public hospital. For example, a private hospital known as NYU Langone has under 5% of its patients lack health insurance, but right next door is Bellevue Hospital, probably the flagship of the New York public hospital system, where they have large numbers of uninsured patients. So you have to ask yourself, how did that happen? Yeah.
Boston City was in rough.
It's yeah, but there was a time when the different medical schools all had services at the public hospitals. I believe that was true at Boston City. It was true and certainly at Bellevue, and so the public hospitals were used as teaching hospitals by all of the academic centers. When they decided that in New York, which I still know New York the best, when they decided that Bellevue couldn't be run by Columbia, Cornell, and NYU anymore, and gave it to NYU, Columbia was assigned to Harlem Hospital. That's where I did my clinical training. They were very unhappy about that, and Cornell decided not to have a city hospital anymore.
Thank you so much for coming. I wanted to also thank you for the focus on data. And I was wondering, it feels like when we talk about racism, I'm right here, sorry. It feels like when we talk about racism, we're often still trying to prove that it exists. And I think some of the graphs you showed about redlining and sort of this historical legacy of racism, it feels like we're always at step one. And I was wondering how you think we can actually get beyond this need, I think, as public health practitioners, to prove that it exists, to actually truthfully addressing it.
Well, for me, here's what I think. I think that biologically, all human beings are equal. And if I believe that, then I should have to account for the inequalities in health outcomes. And that's all I have to show you that we have a problem. The fact that we divide our population into racialized groups is due to our legacy. It's not a natural division. It's one that is based on history. So I would say if we all agree that all human beings belong to the same species, which credible scientists used to disagree about, that we believe that we have fundamentally the same biology, then the existence of racism is supported by the data alone. Just tell me another reason why we see these mortality gaps by race in this country. The other reason that people might say is they continue to be people who make the case that there's genetic variation that is both linked to race and health risk. And then the other one that, as a culture, people of African descent in the United States, are just have had such a sad life that they're not able to make sensible decisions anymore. That was what DuBois was arguing about against a century ago, right? When he was pointing out that in spite of everything, life expectancy was increasing, that the population of blacks was increasing, that the predictions that Hoffman made were not supported by the data. But if the data were enough, we wouldn't still be having these conversations. The data aren't enough, unfortunately.
Hi, I'm over here, in the front.
Hi.
How are you? Thank you for your talk. This question is not from me directly, but from someone who couldn't stay the rest of the time. But it is a very interesting, loaded question. But basically, given what you were talking about before, so pointing out, the really adverse health outcomes and SES outcomes of Black people, and how, back in W.B. Du Bois' time, and how that's still relevant today. When it comes to, Black people who are descendants of slavery and who, generationally have undergone all these different things with Jim Crow, et cetera, do you think something like reparations is a public health or human rights issue?
I do.
Over here.
Hi.
Dr. Bassett, thank you so much for your work. You're a real inspiration and throughout your career. And I wonder, from your perspective as somebody who has worked closely with policymakers in New York City, what you would say would be your top priority. I know it's hard to pick one, but a top priority at either a city level in New York City, for example, or nationally for where health policy should go to address the challenges that you've identified.
Wow. That's a really important question that I should have asked myself before I came here. Because I don't have a single answer to that question. But it's not going to be enough to provide single-payer health insurance alone. Because most of our lives are determined outside of the healthcare system. And it's our everyday lives that make us healthy or not. What we did at the New York City Health Department, if I can tell you, because I was, made health equity the primary goal of my time there, was one, to focus on neighborhoods, because that's what segregation does. It allows you to have geographic targeting and invest in higher cost programming and presence of the health department. I established something called the Center for Health Equity. I used to call them the young insurgents. Many of them were people who I don't think ever thought they would work for a government agency, who went to work every day in neighborhoods where bad policies have created bad health. We also began a whole effort at the health department called Race to Justice, which was to look internally at the agency, whereas in most places, although in aggregate the agency looked like the city of New York, when you started looking at it by hierarchy, it didn't look as good. And start saying not only in hiring, but in looking where money was spent. Dr. Barbeau, who is now the commissioner, spent a great deal of time, because answering a simple question like where does the health department spend its money was something that we couldn't answer until she got to work at rejiggering how we looked at budgets, so that you could tell how, where's the money being spent. And then undergoing a massive training effort. When I left the department, 1,200 people had undergone one-day training, doing this kind of thing. And beginning with the leadership, including the most senior leadership. Additionally, investing and working more collaboratively with other agencies. So those were the 4 kind of prongs. Focus on neighborhoods, establish an internal mechanism, work with other agencies, and that I can't. These are obviously, this is centuries worth of stuff, so I don't expect to see huge changes, but certainly the way in which the department looked at data changed, and that allowed us to have better emergency planning, and that's an important message, I think. That the moral case for addressing racism is strong, but the best case for those of us who work in public health is that by looking at underlying root causes, we do better public health. And equity, the pursuit of equity, is equivalent to the pursuit of excellence in our work.
I have a question. Thank you for your wonderful talk. I'm just curious to get your comments on, we're all agents of institutions, and I'm wondering your thoughts on how we can all be complicit in institutional racism, and how can we strive to do something about it?
Well, what I said to the senior team at the health department is that nobody who's sitting around this table didn't have somebody who took a chance on them. And I'm telling all of you, you're going to have to take some chances on people and hire people that you're not sure will be a great fit. Because that's, all of us, our ears should perk up when somebody says, I think they'll be a good fit. Because, the way the health department looked, that wasn't a good metric. We wanted to change the way the health department, so that it looked like the people of New York City. So it meant that that people had to get outside of their comfort zone, and that's true regardless of our personal identity. No matter how we classify ourselves, whether we think of ourselves as a person of color or as a white person or something else, we all have to interrogate when we're making hiring decisions, for example, whether we're doing what people have done for us, which is also taking a chance so that we can get a more representative workforce. Hi. Did I answer your question? A little bit. I don't want us all to feel guilty. Because what we need to do, we should be mad. I know we're not supposed to ever be angry, especially women, especially black women. But we shouldn't, I don't think that guilt is the appropriate response or sense that we've done harm. We should try and go forward. Yes?
Thanks again for this wonderful talk. I wondered if you could talk a little bit about cities. In my lifetime, I feel like they've changed so much. My grandparents were from Harlem, and that area is nothing like where I went as a child to visit them. And some cities, it just seems like there's no place for poor people and no place for black people. And I don't really even know where the poor people are in cities, and it seems like Boston's on this trajectory to be just like New York. I mean, it's already a very expensive city, but there were still places where poor black people lived, and now I just don't know where the people will go. in cities. And I just wondered if you could talk about that.
I don't want to pretend that I have the answer to this question, but I think that you're talking about gentrification. I think Bill de Blasio was probably the first mayor I ever heard even say the word. So that's how difficult a conversation it is in many cities to talk about gentrification. And the fact is that you need government policies to protect the ability of people who, have our low-wage jobs being able to continue to work in cities. We've all come to think of the geography of our cities as natural. And what I've tried to point out with this redlining case is it's not natural. That it was formed by policy. And we need policy also to protect the diversity of our cities. I don't think anybody, I don't know Boston or Baltimore that well, but I know that nobody who loves living in New York, and I loved living in New York, would find it the same place if it became a place only for rich people. So, it's part of protecting the soul of the city. But also protecting the right of people to housing where they work, and the right of people to affordable housing. So we really need government policy to step in on this. It's interesting, the neighborhoods that I show you lighting up are still Harlem, East and Central Harlem, the South Bronx, which is gentrifying. It was interesting to me to see that when I looked at it again to see whether, given the gentrification of East Harlem, for example, which is well underway, it's said, at least in terms of real estate prices, the mortality rates haven't changed yet. Those remain the areas where the health department, I think, has the most important role to play in terms of promoting health. So there's some kind of disconnect between what people think is gentrification and what people, what's happening to the health of the people who still live in those neighborhoods. Some of it may be public housing, which remains a site where it hasn't been gentrified.
We have time for one more question. My question was, what do you see as the role for education, or the role of education in creating and or eliminating health disparities?
Well, I think that the case I've tried to make is that the problem is not that people don't have the information that they need, although sometimes they don't. There's absolutely a need for people to be educated about what the best choices are about their health. But the principal driver of what we would describe as unhealthy choices are unhealthy contexts in which people don't have access to healthy choices, either because they're not affordable, or they're not available, or because predatory marketing strategies, against which we have very little protection in this country because of the First Amendment rights of corporations, are directed to poor populations. Studies done in New York, for example, show in the neighborhoods that I highlighted that ads for unhealthy products occur many-fold more commonly than they do in wealthier neighborhoods. So all of those factors, rather than thinking of uneducated, ignorant individuals, are more important. Thank you very much.